So welcome everybody to our mastermind of our Portability Insiders. We're very thrilled that we have Anne-Marie DePalma tonight to talk to us. And of course, our masterminds are a think tank, so it isn't just Anne-Marie and I talking and Anne-Marie, Patty and Patty talking, it's all of us talking. That's why the chat box we're going to reserve for a couple of things, which is including your name, but if you have something to say, let's talk. Again, Dental Portability has my PACE AGD certification, and I already have our subject code, our CE, ready for tonight. In order to get that CE, well, let me tell you first, she's not here yet, though. Lindsay Hill, I'm going to get my thing out of the way here. Lindsay Hill is a new member, as well as has helped me out tremendously. I'm going to go over live to the Dental Portability website to show you what you have an opportunity for now that Lindsay has helped me to do. I wanted to have the opportunity of anybody that isn't here for a course can listen to it later. And what I have now set up is that you can get a CE, a PACE CE quiz. Okay, what that does is you go over to the website, you go to the Insiders section. Of course, you have your code. When you sign in, you automatically should be logged in to be able to access the Insider things. You can listen to the course, and if you haven't taken it already, you can get a PACE. It's 5 easy questions. So Lindsay has designed the questions, helped me design the questions, and they'll be loaded within the next few days for all of the courses since January of this year. So if you've missed any courses since January, you'll be able to go back and listen to them and get the content. Of course, to get qualified for CE, it takes 2 parts. We have to have a course description, which I've written over here with the help of Anne-Marie, of course. And I need your name, both first and last, in the chat box. Patty Beeson is keeping track, and I need to have this because I have to show that you're here. See, when it's a live presentation like this, you don't have to do a CE quiz. If it's a recorded conversation, you have to do a CE quiz. So because you're live here, I need your name in the chat box here. Thank you. So as long as we're talking about that, let's get going with talking about who's here. So this is where we see if your microphone works. So Angela, are you here? Say hi, Angela. Come on, Angela, I know you're here. Angela Craig? I see her there. She's not talking. Carol, Roselle, are you here yet? Nope, no Carol yet. Kathleen Fernati, nope, she's here yet. Cheryl said she'd be late. She's our friend in Hawaii, and so she said she'd be late, but she'd be here. But I see Denise. Are you here, Denise?
I'm here. Hi, everyone.
Terrific. Barbie, did you confirm that you? Thank you, Denise. Barbie, did you confirm that you were going to be here?
I did.
Oh, maybe again, you're probably under Lynch on this list too.
By the way, she's on my list. She's on Lynch. As Lynch.
Okay. All right. Diana Corbin, are you here? Not yet. Jan Palmer got called away, so she's not going to be here. But Jean is going to be here. Jean gets extra credit. Jean, and you and Jill get extra credit because you're here first. So hi, Jill. Say hi. Jill, when are we going to get you to lead one of these?
Hi.
Now, you'd be awesome. Warning, I'm coming after you. Jill, are you here yet? Jill Rogie? Not yet?
I'm here. I've been here. Jill Rose.
Oh,
okay.
Okay, thanks, Jill. Oh, there you are. Okay, great. Joy. Joy is going to be our presenter next month. She'll probably calling in. I see Kendra's here, and Kendra didn't confirm. So, hi, Kendra.
Hello.
There she is. I'm feeling better at this point of the day. How about you?
Yeah, sure.
I told Kendra at 8 o'clock this morning.
All good.
All right, so Karen Jordan, are you here? I see your name over there. Karen, say hi. All right, Karen, let's see if that microphone will work. I want to hear from you. All right. Maybe we'll get it going a little bit. Are you here yet, Catherine? Nope, not yet. Kimberly's here, though. Say hi, Kim.
Hi, I'm here.
All right, the other Kimberly. Not yet. Lindsay. Not yet. Bree, actually, I know her is. Lucy, you're here.
Yep, I'm here. Hello.
Terrific, thank you. And by the way, it looks like you got some super things going at Young Dental.
Yep, a lot of good
Excited
things.
excited about what your posts are. And Barbie, there you are. We'll get your first name again, I promise.
Thank you.
Nancy Brohan, say hi.
Hiya, hi.
Terrific, glad you're here. Natalie, I think I just saw you come in.
Hi, everyone.
Always great to see you. By the way, I especially liked your joke this morning. Just saying. They're so good. Nicole, are you here yet? Nicole Fortune? No. Paige, are you here on the phone or anything? Paige is coming home from an office, so she said she might call in if she could. How about Pam? Pam? Not yet. Pam did our test of our online testing system, so we're curious to see how to hear from her. Patty B's here, of course. I'm here. Robin, say hi. Robin, I know you're there. I see your microphone, but we don't hear you yet. Nope. Rosalie thought she could be here, but then she got called away. Sandy Rago, I don't see yet, but I see Sandra Berger.
Hello.
There she is. And my Susie, there you are. Say hi, Susie.
Hi.
Hi. Teresa Seaman, I didn't see you sign in, but I mean, I can see you're just here, so say hi, Teresa. Teresa? I see you there. I don't see the microphone on. And Amy Kruger replied, but she's not here yet. So other people will come sign in as they arrive. As I'm speaking to you, my phone is going off because I'm getting notifications of people receiving what is our brand new newsletter. We just finally got it going, and it actually was scheduled to go out at 7 o'clock tonight. So I'm going to take you over and show you a little bit of what it looks like, because it's arriving in your mailbox as you're listening here. But to give you an idea of what it's going to look like, it's get into a preview mode here, and if you get on the website, it's going to look like this, but it's also designed for you to be able to read on your phone. And when we have these things like this really interesting article about this new biofilm nanoboxing, what it does is it brings you over to wherever the website is that we've taken the information, or more often where you're going to go is to some recent Q&A and keeping you up to date on all the questions and blog posts that I'm answering. One of the things I want to mention to you is there are some blog posts that are for the general public, but then there's also insider Q&A. So there are some of these that only you as a member of being an insider gets access to. So we've really got the website going with lots of different opportunities. I'm going to show you a couple of more too. For example, with our dental podologist consortium meeting, everyone that's an insider is a member of the consortium. Our next meeting is on the 9th of June. And with that, before that, you will be getting a Survey Monkey, because we have a plan of what we had talked about, as part of our strategic plan about what codes we wanted. And then we had the codes that we submitted this year that we were not successful this first time. I'm listening, somebody's got music going, or is that my computer playing something in the background? It might be. Anyway, so you will get a Survey Monkey within the next 7 to 10 days, and hopefully you'll get that turned around as soon as possible, because your point of view is really important. Also, the calendar is up and running, and it's up and running in ways you can go to the events. One of the things I will tell you, your phone app and the website aren't looking exactly the same, but if you even want to know what this is about, it even says on the calendar, it gives you the course description for the events that we're doing here. There we go, that was my music in the background. Finally, we have next month, our beautiful Joy Void Holmes is going to be presenting on calibration. Now, she does calibration for educators, but she's going to teach us how to do calibration even within our own practices. There are such a variety of ways things are done, and calibration is certainly a key to success. So that's what our next Mastermind will be, and that is on Wednesday, June 19th. If you're going to be attending ADHA, that is, you might be there, but that's what our schedule is already set for. So again, if you haven't done it already, there are 2 parts to qualify. There's a course description and your name. So please put your full name in the chat box so that we do know you're here, and we have it for our attendance records for our course continuing education. So without further ado, I'm going to introduce my friend Anne Marie, although she's got so many, look at those letters after her name. I mean, are we impressed or what? I mean, this woman's been around, she's really smart, and she's going to talk to us about technology and HIPAA. But before she does that, I want to just bring forward again how this specifically applies in a coding setting. When we have the CDT code, it's important for we as clinicians to know what's going on for certainly third-party payment. We know that. Codes also play an important role in creating metrics. In other words, ways to count, particularly as we move toward more of a wellness outcome-based system. They are very important metrics. There's also, though, an aspect of HIPAA. And this is actually designated specifically, this comes from the first pages of the CDT book. And as you can see there, it says the purpose of the CDT code is to achieve uniformity, blah, blah, blah. The important part is what I have highlighted there, to populate the electronic health record. And as part of that, HIPAA designated the CDT code as a standard code set. So what that means is even within our electronic health records, even if you have nothing to do with third-party reimbursement, you still should be using accurate codes. Accurate codes is not the same as payments, it's not the same as fees, it's not the same as coverage. But that's why we all need to be aware of that. And then awareness of HIPAA. Technology and HIPAA, as this has evolved since 1996, and prior to 96 it was talked about, but that's when it officially went into place, and here we are, what, 20-odd years later, and HIPAA is still a mystery for many of us. That's why, again, I'm so glad that I can hand this over to Anne Marie, who, Anne Marie, you tell me when you want me to change the slide. So go for it.
Go for it. Yeah. Hey, hi, everybody. Welcome. So what we're going to be talking about tonight is a little bit about electronic dental records and your patient care. And like Patty said, some of the basic HIPAA requirements that relate to the electronic dental records. So go, Patty. So how did we get here? Well, as Patty mentioned, in 1996, the HIPAA law came into effect. But as dental practitioners, we really didn't pay that much attention to it. It wasn't until 2010 when the Health Information Technology for Economic and Clinical Health Act was signed by President Obama as part of the Stimulus Act. Now, the Stimulus Act provided monies for construction, for child care, and for this HITECH Act. Patty, click. And without the HITECH Act, we wouldn't have as robust, no matter what your political opinions are, of the Affordable Care Act. With the HITECH, it provided monies to medical practices in order for them to move towards electronic records. However, dentistry wasn't included. Yes, dentistry is part of healthcare, but dentistry and medicine really don't talk to each other. So unless a practice was 30% or greater of receiving Medicaid or Medicare monies, so some sort of federally funded monies, the practices did not have to fall under that Affordable Care Act, HITECH Act information about becoming electronically dental records. However, over the last few years, a number of states and a number of entities have really pushed this forward. So in 2011, Minnesota required that all electronic prescriptions be done. And in 2015, Minnesota also required that dental offices, dental practices, general dentists, oral surgeons, and orthodontists have electronic dental records. In 2016, New York came up with electronic prescriptions, and I'm in Massachusetts, and next year, as of January 2020, any controlled substance will be required to be submitted electronically. So as far as prescriptions, a lot of states are moving in that direction. Yet, there are other entities, such as dental insurers, that require electronic dental records. So for example, several years ago when I was training an office in Rhode Island, the only reason the Rhode Island dental office was moving from paper towards an electronic practice was that Delta Dental of Rhode Island was going to reimburse that practice less if they submitted a paper claim than if they submitted an electronic claim. And here again in Massachusetts, there's something called the Mass Highway, which is a secure communication, again, between medical practices, and dentistry is not included right now, but any transmission of PHI or protected health information of a patient must go through this Mass Highway. So if a patient is seen in a hospital and then is transferred to a rehab or a nursing home or even to their private physician from that hospital, they have to transmit that information electronically through this Mass Highway. So as you can see, electronic dental records is a moving target. There really is no set date for actually moving towards everyone being a paperless or a chartless practice, and there are differences between the two. How does a patient move through a practice is the most important thing when you're looking at how an electronic dental record works with your patients. The patient is the #1 priority in any dental practice. So all of our electronic dental records have to go back to that priority. What is best for the patient? Think about your medical record. Over the last few years, because of the Affordable Care Act and high tech, we have seen you go to your medical doctor, you get your lab results quickly. You can go to your patient portal and pay your patient balance, or get results of your tests, or email your provider. All of that comes from the High Tech and Affordable Care Act. Again, dentistry hasn't evolved to that point yet, but that's what it's all about. It's providing better care for our patients through the electronic media. Okay, Patty. But there are pros and cons to going paperless or chartless. And a lot of offices claim they want to be paperless. But when we sit down and we actually determine what is the difference between a paperless practice and a chartless practice, they often say, no, wait a minute, we need to be chartless. A paperless practice is one in which everything, all communication, all charting, all note-taking, everything is done electronically. We're communicating with our patients via text messages, sending their bills electronically, sending all of their insurance through the electronic channels. Whereas a chartless practice, which is what most dental practices really strive for, is some paper is generated, but a lot is still done through paper. You may still even call your patients to remind them about their appointments or to ask them a question rather than sending it electronically. Or you might be still submitting some claims electronically if you're doing secondary claims. But a chartless practice allows for standard terminology between practices on the same software. It helps speeds up data. It's definitely a space saver because it allows for that record, that paper record, either to be discarded or saved within your state's rules and regulations and stored elsewhere off-site, or digitally recorded. We can share information such as digital photography and digital radiography much more easily than if we had a film or a photograph of the patient. So that can be transferred to referrers, or to insurers, depending upon what the patient's needs are. Yet, there are also problems associated with chartless or paperless practices. We have definitely infection control issues. How do you maintain infection control on a keyboard or a mouse or a touch screen? Patient confidentiality issues, and we're going to talk about HIPAA, are a major concern. Security issues, and we're also going to be covering a little bit of that tonight as well. And then when a practice uses a lot of digital imaging, whether that be intraoral scanners or sensors or PSP, phosphorus plates, or 3D scanning, if the practice is using a lot of imaging, as we know, images take up a lot of space on your phone, on your computer. It's the same within a dental practice. It takes up a lot of space on the server or the housing computer, the brains of the practice. So oftentimes practices need to have large servers to maintain all of that digital imaging. And sometimes practices don't have the most up-to-date technology in terms of computers. So that can also be an issue. Patty, go ahead. So when we're looking at any of our dental software, whether that be Dentrix or EagleSoft or PracticeWorks or Curve or Open, whatever practice management software that you are currently using in your practice, one of the big concerns is, how do you get help? When you're looking for information about your software, how do you get that? Where do you look to gain that knowledge? Do you have someone that comes in from the software companies to help your practice and do some in-office training? Or do you get information from a website, or do the companies remote in? How do they help you understand your software? And that's so important in today's dental digital environment, because we need to understand how our software works, even as hygienists or business team members or the assistant in the practice. Everyone needs to have some understanding of the why behind what their software is doing. Most practices, most team members in practices are just surviving in their software. They're not really understanding and using it to the fullest. So for example, one of the simplest things, how do you log in or out of a software, can affect what can happen to that software. So it might not blow up the computer, but it might cause someone else in the practice to have an issue. I say when I do trainings that it is often a domino effect. One thing that one person does can affect someone else, can affect something else within the software. So how do you understand the total package of your software? And then what does your practice do for backups? Oftentimes when I'm in a practice, I will ask, what do you do for a backup? And many times, whether that be the office manager, the business manager, the hygienist, or the assistant, I get the blank stare, the crickets. Then, wait a minute, our IT person handles that. I don't need to know that. Yes, you do. You need to understand not all of the nitty-gritties of what happens with a backup, but what does your practice do for a backup? Patty, next slide, please. Because there are 140,000 hard drive failures each week that occur. Hard drive failures are a fact of life. Next. Oftentimes when I'm in a practice, I look around and I will see the CPU, or the central processing unit of the computer, is on the floor. What's on the floor? Dirt, dust. Dirt and dust are the enemies of the computers. So if a computer is on the floor, its lifespan is going to be less than if it was up off the floor. As well as most computers, when they hit that 5 to 6, 7 year mark, tend to have some problems. They tend to slow down. They tend to have some glitches. Things tend to happen. And one of the things that's really going to happen is, as of next January, Windows 7 is going to be retired. So Microsoft is not going to be supporting it. When Microsoft stops supporting something, then a lot of the hackers and a lot of the people who do nefarious things tend to get into the software. And you probably, your software vendors and providers aren't going to be doing updates to the software. So this is something that team members need to understand and need to know about. What is your computer running on? I was in an office last week where the computers are Windows 7. I was in an office about a month ago that they're still running XP computers.
Oh my God.
XP's been sunset for a while. So these are things that even as hygienists, we need to understand. We also need to know, are they backing up the software? Are they backing up the entire computer? How do they restore it? What would happen if you had a crash of your server and your data? As a hygienist, most of us wouldn't be able to work because our data is all, our x-rays, our charting is all in the computer. Does your office have some sort of backup plan? And I hear that often. Oh, I can't go to a chartless or a paperless environment because the computers are going to crash. Yes, they are going to crash. It's a fact of life. But be prepared. You know, what's the old Girl Scout motto? Be prepared. So there are a number of companies out there that provide services that test and make sure that everything is validated and confirmed, that everything is appropriate. Next one, Patty. Go to the next slide. So, what percentages of businesses you think lost their data for 10 or more days, filed for bankruptcy immediately? So think about your practice. If your practice lost your data for 10 or more days, and I've been involved in a practice that lost their data for about 7 days, they were completely down. 50% lost, filed for bankruptcy immediately. And within a year, 93% filed for bankruptcy. Think about that. Think about your own practice. You need to know how they are backing it up. Is it tested regularly? Because you don't want to be a 93% practice. Next, Patty. Thanks. And as part of HIPAA, most offices don't realize this, but a specific rule of HIPAA requires that a security risk assessment be done. Now, we do risk assessments for caries, for periodontal disease, and for oral cancer. But most offices have never heard of a security risk assessment. And a security risk assessment actually checks and sees what are the vulnerabilities of your practice as far as security. There are, again, a number of companies that offer that service, but the government, as you can see here, offers a free risk assessment analysis for your practices. So you can just go to this website and it'll ask you a whole series of questions. You know, where is your server? How is it firewalled? How many people have access to it? So these are things that a number of offices have had issues with security. Next slide, Patty. Because these are some of the offices that have been on the HIPAA wall of shame. These are practices, dental practices, that have had some sort of breach. A breach is a breakdown in the security of the practice, whether it be a laptop that was stolen or someone had access to information that they shouldn't have. when I go into offices and I ask about security and whether or not everyone has their own passwords, again, oftentimes I find that everyone's logging in with the same password, or everyone knows everyone else's passwords, or everyone has multiple types of security levels. We don't want that. That could cause a breach within the practice. And if it's 500 individuals or more, it has to be reported to the HIPAA police. And the HIPAA police are the Health Office, Federal Office, Health and Human Services, Office of Civil Rights. That's where, if you had a breach within your practice, you would have to notify them. If it was over 500 people, you have to notify your local media. Think about what that might do to your practice, as well as every single person that was involved in the breach. Think about the breaches that we hear every day about all of the different stores, the Targets, the Home Depots, all of those types of things. The reason we hear about those is because it's greater than 500 people. So next.
Can I ask a question? This column then, this center column, is this the number of records that were breached? Is that what that number stands for?
Correct, yes.
So we have
Rainbow
one
Dental
that said 3,202, or this one said 3,600, because what, they lost their whole server, they lost something big, and that's the numbers that it adds up to?
Probably. These numbers I obtained from the HHS website. If you go to the HHS website and you look at breaches, these are broken down by, most of them are medical facilities. So there's not as many dental ones, but we don't know if there are a lot of dental within medical. So they could be higher numbers than what you're seeing. So for example, the Rainbow Dental Care had 10,000. What that was, I don't know. If that was a whole server or if that was a computer, I don't know. It doesn't give you the specific information. And they have to remain, offices that are listed on the wall of shame remain there for about 90 days. So one of the things that is really important to help protect the practices is everyone having their specific security level, as well as a specific password. And most of the dental softwares out there have software levels based on the position that you are within the practice. So if you're a hygienist, you might have a clinical access. If you're a business team, you might have that, a practice management aspect. If you're both a business and clinical, you might have a hybrid. But you shouldn't have the same, a clinical person shouldn't have the same access as a business team. And everyone should not be logging in under the same passwords or knowing everyone's passwords. Things need to be secure as you work through your software. So next. So what are some of the things that HIPAA looks at? The zip code +4. And the reason we do that, the 5-digit zip code plus the 4 extra digits, is to help prevent insurance fraud. Insurance companies will not send payment to a post office box. They need a legitimate address. And those 4 extra digits offer a legitimate address. Next. You can just click right through these, Patty. So, great, thanks. This no cell phones in operatories is basically because everyone has a camera on their cell phone these days, smartphones. Someone could inadvertently take a photo of someone in the next chair or the schedule. That could be a HIPAA violation. Always verify your patients. Now, most dental practices, you know your patients. They've been coming to you 5, 10, 20 years within the practice. But think about when you go to your medical provider. What are the 2 things that they always ask you? For your medical insurance, copy of your card, and for your photo ID. I travel a lot, and lately, a lot of the hotels require photo ID when you check in.
Yep.
Everyone is asking for photo IDs. So as a dental practice, it's something we should get into the habit of, especially if your practice is a very Medicaid-centered practice. Not to say that there's fraud that occurs in other types of practices, but it seems that there happens to be a lot more in those types of practices. And also have a guest network for your employees and for the patients that are in the practices. What happens is a savvy person can get into your actual practice management software and see potentially information. If you're using the same network for your reception area as is on your clinical information. So you want to keep those two networks separate. You want to give your patients and visitors some access to the internet as they're waiting, but yet you don't want them to have access to any of your protected health information. Next slide. If, for whatever reason, the HIPAA police, the Office of Civil Rights of Health and Human Services, came into your office, whether that be from a patient complaint or just as a random evaluation, they have a 7-year look-back period. So if there was ever a complaint within your practice regarding HIPAA, the HIPAA inspectors could look back 7 years. And any employee who violates HIPAA can be held liable. It's not just the practice. It's not just the doctor. Think about your license. Next.
Sorry, it's stuck. Hold on. There you go.
Okay. Yep, there we go. One of the things that I often see is about emails. Emails are what we call MAPI compliant. However, they are not HIPAA compliant unless the email is actually encrypted, either by your internet provider or your IT provider. Your MAPI means when you read, it's computer language, so that when you read your email on a phone or a tablet, it recognizes that it has been read on your computer. And that's really great. You know, we don't have to reread emails. However, HIPAA requires that when you're sending emails that contain protected health information, that you encrypt them. Now, for example, sending a radiograph to an office. If your email in and of itself is encrypted, that's great. But if you're just sending your email through Outlook or Yahoo or AOL or Comcast, whatever you're using, and it's not encrypted, and you have protected health information included in there, that could be seen as a HIPAA violation. Yet there are companies out there that do encrypt emails, so that when you think about an email going through space and time, it goes from your computer to the internet provider's server, from that server to the recipient's internet provider's server, and to the recipient's email. And along that route, anywhere along there, it can be hacked or looked at. However, some of the companies that are out there that work to encrypt information or serve as a server will send a message to the recipient to say, okay, we've received an X-ray from Dr. X's office. You need to log in, we'll send you some information, and then you'll be able to see everything encrypted. So there's a couple of different ways of looking at protecting your practice's email. So next. And we talk about encryption all the time, but do we really understand what encryption is? Think about when you're ordering something on Amazon. You put in your credit card information. It goes from your server to the Amazon server, gets all jumbled up, Amazon reads it, and then you get whatever you're purchasing today. But what happens is that server that receives the information, once it's encrypted, it needs a key to unlock it. And that's what encryption does. It unlocks the key. Next. So a patient cannot consent to a dental professional sending information to any other medical professional through unsecure methods. So your HIPAA forms should always have some information about how you are sending electronic information. Also, make sure that your forms are the 2013 forms. The original forms were the 2003, and many offices have not updated since 2003. But those 2003 forms did not have any information regarding the electronic transmission. That's why you need to make sure that your practice is using the 2013 form. Next. So think about what your practice and how your software works for HIPAA. How do you deal with your schedule? Often practices will have two screens, one facing the patient, one away from the patient. Oftentimes there may only be one screen situated right in the middle, and the patient can see it with all of the protected health information of other patients. So think about what your practice does for scheduling and how you're compliant. How compliant is it? And how compliant is your overall software? Okay, next. We're now looking at a lot of differences in dentistry, not only in terms of how we practice. When practice management software came out in the mid-1980s, most practices were 1, 2, 3 doctor practices, and usually 1 or maybe 2 locations. But now, in the dental environment, we have a lot of DSOs that have multiple doctors and multiple locations. For those single or 2 doctor practices, having a server in each location worked really great. Now with the DSO market, we need to have a lot more. We need to have a central location. You can't have a server in every location. So a lot of the DSOs or multi-location practices have gone to cloud, just as we in our everyday lives have gone to the cloud. There's so many things that we do today on the cloud, just in our everyday life. But there are differences. There's pros and cons with both a server-based environment and a cloud-based environment. One of the biggest issues about cloud-based is the internet speed. A lot of offices say it takes forever to upload or download images to the cloud. And that's a result of the practice's internet speed or the network within the practice. How is that all set up? Questions the practices need to look at and determine is what is the support that the practice is going to get from the cloud-based or the server-based software, especially in terms of HIPAA, and who owns the data. A lot of times, a lot of the server-based companies, they actually own the data. It's not the practices. Whereas in other instances, it is maintained by the practice. So these are questions when the office is looking towards a server-based versus a cloud-based. And what are the support fees? There are a number of different fees regardless whether you're using cloud-based or server-based technology. You need to have a dedicated IT person, or do you have just everything on the cloud? So it just depends on what type of practice the software is using. Next. And just like we've been talking about practice security, we also need to understand our own personal security. Every day I'm getting millions of spam calls. Don't ever hang up. Don't ever speak with them. Just let them ring. Let it go to caller ID. Don't accept any freebies. Never wire money back or deposit a check. You get a check in the mail. Oh, great. Oh, I won something. When you send that check back, they now have your bank information. A lot of people have been scammed by doing that. Always be careful when you're using public Wi-Fi. Public Wi-Fi is great. Just don't use any sensitive transactions. Don't put your credit card information or your any protected information. Always read your bank accounts and checkbooks and credit card statements. Always check your emails. Make sure you're checking the spelling of an email, because sometimes it's a little off. You get a hint that this may not be from Apple because there's only one P or there's a double L. Whenever you're sending secure information, always make sure that you're using the lock or the HTTPS symbol. And shred anything that has your personal identification on it. You know, you get so much junk mail, shred that. Patty and I travel a lot. You shred your keys. Your keys actually, did you know your keys actually contain your credit card information? So little things to help protect yourself, as well as protecting your practice. So we've talked a little bit about our electronic dental records and basic HIPAA requirements. So are there any questions?
I want to get this started with myself because you do the training for EagleSoft. I know based on a conversation that I had with you and Millie back in the beginning of this year about CDT updates. Talk about that process and what you see out in the field and what everybody here might need to consider on what's going on even in their own offices or the various offices they're working in.
Correct. All I know is EagleSoft, so I don't know any of the other softwares, but they all would probably have something similar. EagleSoft does not automatically update your CDT codes. I go into offices and I have seen for years things that have not been inactivated or they're still using an old code. For example, at the beginning of the year, an office I went into had not updated to the 2019. They had submitted for an appliance, got it rejected by the insurance company because they were using the old appliance code. There were 3 new codes that came in as of this year for appliances. They were using the old one. So of course they were going to get rejected. So what ends up happening is you have to contact your individual practice management provider. So for EagleSoft, it would be Patterson, and they can run a utility that quickly brings in all of the new codes. It doesn't inactivate any codes, but it will bring in all of your updated codes. And you're supposed to be submitting your most up-to-date codes as well as what you're supposed to be coding for what you do.
So again, as a follow-up to that then, Anne-Marie, is if there is a code that is, for example, deleted, we still need to keep that code in our system for record continuity. How would a practice identify that, though, as a code that's no longer active?
It would, so for example, in EagleSoft, there's just a click button that says active or inactive. It still remains in the patient record. It is still there. You're not deleting it. Anything that has had a history to it cannot be deleted. I had a question from an office today, exactly that. They wanted to delete a code. And I'm saying, no, if you've used it for any reason, you can inactivate it. And it's in the service code list themselves.
So, but it's not done through the updates. That has to be physically done within a practice. Did I hear you right in saying that?
Correct, correct. The update only brings in new codes. doesn't inactivate the office. I've seen a lot of offices that are still using the 1, 2, 3, 4, 5 for the fluorides, where they still have them listed as active when we know for years they've been inactive.
Yeah, okay. What about training? What do you see as far as training and retraining, or what do you think from your perspective is important about that part of dentistry and our
training?
Yeah.
Training needs to happen on a regular basis. And it's a problem for offices because in order to do training effectively, we know that the best training occurs when there's dedicated time. However, dedicated time means loss of production because you need to be involved in the training. You can't see patients and be trained at the same time. So a lot of offices will push that to the back burner. Nope, nope, nope. We don't need training. We don't need training. We're fine. We can call up. We can do whatever. But it wastes more time and more money not having the training because you're on the phone or you're on the internet. You're searching for these things. When in actuality, if you just have the training, close the office for a few hours or half a day or whatever needs to be done, and get the training, it answers a lot of questions and it solves a lot of problems before they even come up. And this is a major concern because offices just don't spend the time to train.
Okay, I want to open it up now to the rest of the audience here. Ask some questions. Ask Anne-Marie questions. Let's have some discussion here. Remember, I know you guys, I'll call on you.
Yeah, what do you see in your practices?
Who's here?
No questions? Come on. What'd I do?
Natalie.
Put everybody to sleep?
Natalie, you've been all over the place and you want to talk to me about your assistants and assistants' point of view on this discussion of HIPAA as well as the whole technology end.
We're all over the map as far as technology. Some offices are still using paper charts. Some are half and half, no paper charts, but they're scanning in forms and things. And there's even a few offices out there that are still using traditional radiographs with the processors and things. So we're all over the place.
And that's one question that I get a lot about scanning. Do I have to scan everything? And the answer is no. Whatever your practice deems is important. Some offices will scan every single piece of paper. Other offices will only say, oh, I'm going to do the progress notes and maybe a medical history. Other offices say, nope, as of X date, we're going electronic. All of that is our record and our historical record, and that's it. From here forward, we're in the electronic. We're not scanning anything. So there's no right or wrong answer to that. I still do see some offices that do have manual x-rays and processing and all of that, but they're losing out. Not only in terms of technology is passing them by, but as a result, their patients are passing them by. Because patients are so technology driven right now. They want a practice that has technology. And if it doesn't, it's slowly dying.
It's also the matter of salability of that practice too. I mean, eventually somebody's going to sell that practice and you're not technologically savvy. Yeah, who's going to want to buy it?
Correct. I told many offices that. Yep. You're going to get less money for the sale.
Yep. Sandra Berger, I see your microphone on. You have something to add here? Question?
I do. So, technology does not make an office HIPAA compliant, correct? So you can have a HIPAA compliant office with those manual x-rays and all that.
Correct, but it still falls under. So, for example, are the records locked up are the paper records locked up?
Okay,
So
right.
if it's not, I go into a lot of offices that still have paper records, and the records are out in the open. Anybody could see them.
Okay.
Okay, so
Yeah.
that's a HIPAA violation. I'm working on an article where it talks about both the paper world and the electronic world. So HIPAA covers everything, any protected health information. There are, if I remember right, 13 or 18 identifiers, some of which are technology driven, but some of which are still in paper. So yes, it covers across the board. But more and more offices are technology driven than paper driven.
Yes. Oh, I understand. I just have a funny thing. I have a family member who is incapacitated. That's not the funny part. I am the person in charge of their, they're completing all their forms. I have, all the documents needed, and I called, I've called so many offices. I called the health insurance company to get the disclosure agreement, and they wouldn't even talk to me about the disclosure agreement because I wasn't the patient.
Correct.
Oh,
Yep.
HIPAA,
Unless you sign that disclosure form.
but they wouldn't even give me the disclosure form. It was
so
like,
the patient, do you have power of attorney? Do you have power of attorney?
I have power of attorney. I had I have all the papers. Patient is incapable of signing it. They're, comatose, and they wouldn't give it to me. And they're 300 miles away. So I actually had to get someone to sign their name illegally to get the disclosure form. So HIPAA can actually work against you. I mean, it can be, you have to be smart when doing it.
Correct.
So.
There are any number of issues surrounding it, yes.
Yeah.
That's an unusual one. I have not heard that. But yeah, it can happen.
It happened last week, yeah. But
so let me ask a question. Oh, I'm sorry, go ahead.
No, I love the cell phone part. That was something I didn't know, that it was not HIPAA compliant.
Think about, there are a lot of social media pages out there that people are putting patients' information out on, which is great because we need to share and learn, but yet you have to be careful when you do that.
Anne-Marie, I see a really good article out of that part.
Oh yeah, I'm working on it.
Yeah.
Oh my gosh, what they do.
Who don't want to leave their phones anywhere.
Right.
I walk into my doctor's office and they have their phones there, and that's
a huge problem.
Yeah, I don't like it. So great. Thank you.
On a follow-up to that, again, it's for HIPAA and all that stuff, but the question of who owns the data, I'd like to explore a little bit more, because that ownership of the data, it isn't really cloud or server. Isn't the data the patient's? Isn't that what HIPAA is all about, is to protect that personal information? Yet what happens, and what I think I just heard Sandra describe, is it can be so protected that I, as a person, almost everybody else seems to have access to my data except me, because I got to jump through all these hoops to even get my own data. Because, well, even it relates in my brain to, and Anne-Marie, you probably don't know the answer to this, but you can make something up if you'd like. Right now, with interoperability, interoperability means we've got all these different medical systems that can talk to one another. And we saw that in the beginning, you talked about the requirements of certain states and how this is coming on. It's slow, but it's coming on. Yet, does EagleSoft talk to Gentrix, talk to Easy Dental, talk to any of that? Does anybody interoperate with them?
No. And even within the medical community, I'm working with a couple of major hospitals, one of which has EagleSoft and has a dental clinic that has EagleSoft. The hospital is mandating that they go to the hospital medical software. And there are two major players in the medical world. One is Cerner and the other is Epic. Epic does not talk to Cerner. Cerner does not talk to Epic. Even in the medical world, it doesn't happen. They're talking about down the road maybe making it interoperability, but this was one of the things that was supposed to come out of the HIPAA Act, that it was interoperable. It just never happened.
And even for me, I have 5 different my charts in 5 different hospital systems. It's insane. Okay, but from another point that I brought this up in many courses is when we send records, why don't we send anything more than x-rays? Anybody have any answer to that? Somebody requests their records. All we ever send is x-rays, right? Why?
I had an office call me today regarding they have a patient who they have had issues with in the past, and this patient has moved out of state, and the new office is requesting information, and normally they would just send the information to this new office. However, because they have had issues with this patient, they want this new office to send them a request form. But again, they're probably only going to be sending x-rays. They're not going to be sending the complete record. Why? I don't know. It's a good question.
But and this is from the perspective of even using the 4910. We're getting tremendous echo here from somebody's line. Anyways, even from using the perspective of the 4910, if someone had periodontal therapy, whether surgical or non-surgical, and the current office they're in does not have a record of one that took place and self-reported by the patient isn't good enough, we can't even use the 4910 code.
Correct.
It's as simple as that, yet nobody ever questions it. And isn't what we write in our records the most important part of the diagnostic aspect? It's not just x-rays. X-rays are after the fact. And I was really surprised. I went to an office for a sleep evaluation, a sleep study, and they did this and that, and they were purported to be this high-tech office. Yet when I asked to have my records sent from one encrypted office to an office that has encryption, that office did not have encryption. They said they could print out all my digital records and send them in the mail. I'm like, or in a fax. I'm like, really? Really? The incongruity of it is like, wow. And I think that's part of your message here, isn't it?
Yes, it is.
Yeah. Any other comments? Anybody here? Paige Seaborg, who didn't make it here tonight, she had been in for, 39 years or something. And in her, we're getting ourselves. In her journey to find another job, she said one of the biggest challenges she's had is one day she's using EagleSoft, the next day she's using Dentrix, the next day she's using something else. And it's crazy for her. Anybody else having that kind of thing where you're going and you're having to have all the different trainings, or do you have the trainings, or are you just fumbling through when you get there? Comments, anybody? Denise? Oh, Denise, you haven't been practicing clinically for a while. Did you ever have that experience with the various offices that you worked in?
Yes, but it would start off with whatever office. Let's say I was working in Bloomingdale. Because I was a hygienist that worked in multiple locations. So Bloomingdale, let's say I would be using EagleSoft, and then I would go to the other office that would be in Park Ridge, and they would be using Dentrix. So, you know, you had to either learn quickly, they gave you a crash course, and then just kind of threw you to the wolves. So you did have to pick up on all of those. So like when a hygienist is getting hired in a new office, you're asking them, so which software do you know? Do you know EagleSoft? Do you know Dentrix? Do you know Curve Dental? I mean, there's so many different ones out there that you have to know pretty much all of them because they're not all the same. So yes, I did find that a lot.
Mm-hmm.
Yeah, and I find that a lot too. People just get thrown into their position without even knowing what they need to know. You know, yes, they might have used one software in an office, but now we're using it differently in this. So wait a minute, or it could be a completely different software. It could be the EagleSoft or the Dentrix, and they don't know what to do in the softwares. Yes, they're all similar. You know, they all schedule, they all make, you know, appointments, they all do charting, but each one does it so totally different.
I have two questions. I have one that Robin in the chat box says, we spend a good deal of time calling previous offices to find out when SRP would have been performed so that we can file claims for perio maintenance. Robin, when you do that, what kind of documentation do you get sent, and how is it sent to you? Robin? Does your speaker work? I might see your microphone, Robin. We don't hear you. Hello, Robin? Maybe you want to put your answer in the chat box. Probably having trouble. Yeah, okay. Also, I'm going to, okay, while you write something in, Robin, I'm going to go to Joy. Joy, are you there? Madam Joy, who's going to do our calibration course next month? Joy? Hello? I see her there.
Patty, Jean
Yeah?
also had a good comment in the chat box.
Okay. Okay, Jean, so I see Jean, I see your microphone, so go ahead until we get a hold of Joy or Robin.
Oh, what was my comment about the cell phones?
Yes.
We had a HIPAA training thing last year, and that has been a concern. We have people taking photographs, walking through the office, and so we've put signs around, and you'd be surprised at how many of my patients are just surprised that that's a problem, because that's a concern, you know, and they just don't think about it. I've had people come in, and this is a university town, so we have people come in and they're working on their phones while they're in their appointment, or teenagers come in with their friends, of course, and don't want to leave their cell phones behind. So it's been a kind of a good thing, in our estimation, because people are more engaged in their appointment. So anyway.
Exactly. I had I had a patient when I was practicing clinically in the perio office, and this was years ago, before cell phones really came into being. You know, like, he was a big time entrepreneur, and you know, his time was more valuable than my time type of person. And whenever he came to my practice, he was always 15 minutes late. That was a whole nother issue. But if he got a call, he would have to take it, and sometimes I could stay in the operatory, and sometimes I had to leave, depending upon the conversation. That annoyed me to no end. You know, it's my time, hello, but you know, he was that type of patient, you know, but I can't even imagine thinking about that now in today's world.
You know what, though, but on the shoe on the other foot, my feeling about healthcare has been the opposite. It seems like we can wait forever for healthcare, but boy, when they're ready, they want us now, and our time's not important. I'll be honest with you. I see the signs about the cell phone, and I learned that tonight on this meeting, is when I see the sign about the cell phone, I don't pay attention to it necessarily, because it seems like it's more a control issue. Nobody's ever explained it as a HIPAA issue. Right. Because for a long time, it wasn't a HIPAA issue. It was just purely a control issue. This is our time, and you know what I mean? So it's interesting. I think it might be interesting if the signs were posted that due to HIPAA, that you can't use bring your cell phone in. That would give that a different spin for as far as I know how I would perceive it. So,
right, I think that it's helped when we've explained that it came from a HIPAA standpoint. Valuing their privacy, we have a semi-open concept. So it's, you know, valuing their privacy and their time. And
yeah, and I think that you know, as long as we explain it, then it makes sense to people. But just to have,
I heard of
there's
one
a lot of
story.
arbitrary rules in healthcare. I have felt, because I spent a real large time with doctors in hospital situations for myself in the last recent time, I feel like, when did I lose my autonomy as an adult sometimes in these situations? That's why I kind of go, yeah, you better give me a reason why, or I'm not going to comply. I'm not going to be compliant. So that's part of that issue too.
it's like when you're in the ER, which I've had that experience, and you can hear everything in the next, you know, because it's so nearly by and you can hear everything that goes on. So you're like, oh.
Yep.
How about an adjoining room in a hospital with a curtain? Really?
Oh,
that's real private.
Oh. Yeah, there's.
That's why more and more
Robin,
hospitals, I've noted, I saw a recent article that said more and more hospitals are moving towards private rooms for that reason.
Right.
Okay, we have, first of all, in the chat box, I want to mention, Robin said mainly the verbal communication between the offices, then we document the patient charts. Robin, I'm not sure that would hold up as far as a verbal communication. If anything, that office would probably need to provide a written communication of when that periodontal therapy was done, because just verbal communication on a telephone call is not much different than self-reported from a patient. So from I don't know if legal standpoint would be the right term, it's interesting. But that's one of those things when we think about records, again, why don't we send? We also have in the chat box from Lucy. Lucy, we still all share the same password. When I was asked, I was told that the receptionist needs them the same. You know what, Lucy? Go ahead and say this yourself. Go ahead, yes. Please, microphone.
Yeah, so I asked about, because one of the other meetings we had, somebody talked about the passwords, and she said she needs it so she can adjust for our payroll if somebody forgets to sign in or out, and because we can't adjust our own payroll hours. So is there a way to learn how to set your own password?
It depends on the software. So for example, with EagleSoft, only the administrator can set the under the administrator's login, you set the password. As well as there is security that, yes, you may not be able to change your hours, but there's a place where you can put in a note to say, please change my hours.
Okay.
You know, so there's ways around it, so that's not a very good excuse. Okay, thank you.
If
Any
they
other questions?
Hours, can they change your notes and everything else?
Well, anybody, I suppose. I mean, we sign in under our name, so when I'm putting my notes in, they're going in under my name. But it's still the same well, we all have, I guess I shouldn't say it's the same. Yes, it's the same password. We have our own name in it, but it's the same password. So I could know that I could put Susan in the password and I could change her notes under her name. And somebody could do that to me.
Oh, that would be a good example of exactly what Anne Marie was talking about earlier. Right. That's not good.
No, right, that could be a HIPAA violation. Mm-hmm. Okay. Yep, the HIPAA police can come in, and they are doing fines or settlements, and they can range anywhere from $150 to $150,000.
Okay,
so
good to know.
Depending upon, depending
per
on
violation.
What violation.
Okay.
Yep.
Yeah.
Okay, thanks.
Yep. Anything else? Anybody have any other questions, comments? Well, thank you, Anne Marie. This was very instructive for all of us. Really appreciate your time, your expertise. Again, this is a safe place to talk, and so even though Sandra Berger said, it's all good. It's all good. Again, you're all part of the insiders. Watch for the survey. Please turn that around. Your opinion and your thoughts are really important, and I invite you all to join us again on the 9th of June at 7 p.m. Central. You get an e-bike for that. And then our next insiders. Is that a beautiful picture? So I just got that done. It's for our successful strategies for calibration. Really, really important, because that, again, is, are we all doing something different? Are we giving different people information? And how are we documenting it? And there's so many parts to calibration. So I really appreciate all of you, and you know how to find me. Text me, email me, Facebook, Instant Messenger, any of those ways. I'll get back to you as soon as possible. If you have any questions, please, the questions are really important, and I use them for the blog post, because whatever question you have, other people have too. Love to hear your comments and thoughts on the new newsletter format, and we are all about building the future, and I know that we're up to it. So thanks, everybody, and have a good night.
Have a good night, everyone. Thank you. Bye.
Good night. Thanks.
Night.
Hi.
Hi.